One, we are live.
Good evening, friends. Welcome to the PG Track of the Delhi CSI branch. And today we are coming back after a break of one week because of the Cardiological Society of India Delhi branch conference. The annual event was a great success, and you must have got a chance to listen to so many speakers. And today we are continuing with the second talk of the statistical primer for medical professionals. We had a wonderful, fantastic, simple, lucid talk on the statistical primer in case you missed it, because it's now a must in exams. As a doctors, we must know the basic of statistics, which most of us are often not remembering or not interested or not using. So we had a wonderful talk by Dr. Anil Saxena, who made it very simple, and this talk is available on YouTube and you can listen to that talk also. And today we are going to have the part 2 of this statistical primer, and along with me on this journey we have Professor Sumod Kurian, who is professor of cardiology at Jeepant Hospital. We have Dr. Ankit Bansal, who is Associate Professor of Cardiology at Jeepant Hospital. And we have Dr. Satyavir Yadav, who is Assistant Professor of Cardiology at All India Institute of Medical Sciences. So I welcome you all, and over to you, Dr. Sumod Kurian, to please start the session.
Once again, a very warm welcome to today's PG Track program. As we all know, many times we think statistics is a very dry subject, but if you have attended last week's lecture, we saw how sir can make it every minute, very engaging and lively. And I'm sure all of you are, very eagerly waiting to listen to the second part of the lecture. So I welcome dear sir to come and teach us. As you all know, sir is the director of electrophysiology at Fortis Escorts Hospital in New Delhi. So we welcome sir. Please come and teach us the statistics.
Thank you, Dr. Sumod and Dr. Mohit. It's indeed a pleasure to be here once again with all of you. And I'll continue with my discussion on the statistics, just to refresh some of the concepts that we discussed last time. We discussed about the confidence intervals, we discussed about the p-value and how we calculate p-value, what is the significance of p-value, how should we interpret it. And we'll continue in the same format, that it's not necessary for us to actually learn how to calculate various statistical values or understand the models in detail, do the mathematical calculations. What is important is to know when a particular statistics is to be used. And I also discussed how it is very important to understand the concept of population and sample, that there is a huge population of every disease entity, whether it's hypertension or CAD or hyperlipidemia, or patients undergoing particular procedure, angioplasty or stenting or electrophysiology studies. And whenever we want to do a trial or study, we take a small sample. Now that sample is something that has to be carefully drawn, and it should be of adequate size. And then we randomize the sample into different treatment strategies, group A or group B, or sometimes more groups. And hello, can you hear me? Yeah.
Yes, sir.
So
Yes, sir.
to allocate different treatment strategies for different groups. And the benefit of randomization is that if we do it properly, it makes the groups exactly similar in every aspect except the exposure that we are trying to study, which could be some treatment or exercise or intervention or some surgical procedure, whatever. And we also discussed how confidence intervals are very important whenever we have any statistical parameter, because statistics is a very inexact science. It's not exact mathematics, it's probability. What the statistical models, they use probability to guide us. Because every experiment, when we are having a huge population and we draw a small sample, it leads to some uncertainty. We cannot say exactly that if you take another sample from the same population, we will have exactly similar results. So every sample will give a different result. So there is uncertainty involved. And all the statistical models, they quantify that uncertainty for us by using probability equations or models. So whenever we do we calculate any value, whether it's a mean and standard deviation in this particular slide, or it could be a hazard ratio, it could be any value. log rank test, every value will carry some statistical uncertainty, and quantification of that uncertainty is what the confidence interval tells us. So I gave the example of if there is a large like heap of fruit and we want to know the exact mean of the fruits, and we take a small sample of 50 fruits, we get certain value, but we get a wider confidence interval. And if you take a bigger sample of say 500 fruits, you get a smaller confidence interval, and even bigger sample will lead to further narrowing of the confidence interval because the uncertainty is getting reduced and we get more confident with our point estimate. So we know that if we keep on repeating the experiment endlessly, the true value will be contained 95% of the time within this confidence interval. That is the definition of confidence interval. And this is exemplified in the clinical trials also. So I gave this example that if you do a trial on 4,000 patients with 2,000 patients in each arm of drug A and drug B, we find that we are getting a definite result. So there is a point estimate of benefit, and with the entire confidence interval, the lower bound and the upper bound, they're all falling within on one side of the line of no difference, which is in the center, where it is like hazard ratio is 1. So, but if we reduce the sample size to say half the number of patients, say 2,000 patients, you find that the point estimate remains same, but the confidence interval widens, and you are not so sure about the study result, because if you keep on repeating endlessly, sometimes you will find that there is no difference. So you're not sure of the study results. So this is very important, that whenever we look at the confidence intervals, they should not include 1. So whenever a confidence interval includes 1, that means that confidence interval indicates that you're not sure of the study result. And obviously the p-value there will be more than 0.05. Now, this is just an example to show you how in many studies you will find this kind of table, forest plot, where you see the confidence interval and the point estimate being expressed. And as we can see, many of them are crossing the line of 1. So they include 1. That means they are not significant. And some of them are absolutely on one side. And so another thing that often you will see increasingly in the papers is that after the main results, the authors, they subclassify, they do subgroup analysis. So like in this example, for example, this is the Danish trial, which was done on defibrillator implant in patients with non-ischemic cardiomyopathy. And the author showed that there's no difference with the ICD. As we can see the overall at the bottom, you see the overall difference. There was no difference, but they found some difference in some groups. For example, in the age group less than 59, there was difference. So the ICD was better. As we can see at the bottom, ICD better. So ICD was better in younger patients. ICD appeared to be better in patients who had less anti-proBNP levels. Here it looks this thing better. But if you look at the p-value of the interaction, it narrowly missed the confidence, the p-value. It has narrowly missed the significance. So on the right side, you have the interaction value, whether this interaction was significant or not. And you can see in the age, it shows significant at the top, but others are not so significant. So all these things we must look at when we look at when we read any research paper, we must look at this. Now I will give some further examples of the importance of looking at confidence intervals. These days there's a lot of talk about NOACs being used after angioplasty. So we know that after stenting or after PCI, we use a dual antiplatelet for 3 to 12 months. Different operators like to use some 6 months, 12 months. It also depends on the complexity of the procedure or the lesion. But there is a talk about trying to replace the second antiplatelet with NOAC in patients who are having atrial fibrillation and who require NOAC for stroke prevention. There is a talk that we can probably skip one antiplatelet. We can just give the dual therapy, one NOAC and one antiplatelet, preferably like clopidogrel. Most of the trials have been done on clopidogrel. So there are 3-4 trials. Like for example, the Pioneer PCI trial was done with 3 arms. The rivaroxaban, 2 strategies, and vitamin K antagonist, 1 strategy. And they showed that the bleeding significantly was reduced by the NOAC strategies, that is the rivaroxaban strategies in this example. And this was very significant. All the p-values, as you can see at the top, are significant, but that is not the point. The point I'm trying to make is that they also showed that the efficacy was comparable between all three treatment strategies. But in a small print, it was mentioned that it was not powered enough. What does it mean? Because if you look at the at the hazard ratio was similar, 0.93, 0.95, which or 1.08, which is not very different. So it is close to 1. But if you look at the confidence intervals of this, it could be 0.59 also, it could be 1.48 also, 0.69 to 1.68 in the upper example. So that means it could be very good, it could be very bad. So we don't know about the stent thrombosis part, because what our intervention colleagues are interested in, not the bleeding. Everybody knows that if you give 2 antithrombotics instead of 3, patients will bleed less. But what is important is the efficacy of this strategy, that a patient should not have ischemic events or stent thrombosis. So that was this trial was not powered enough to show that. The other trial, like redual PCI, again 3 arms, 2 using dabigatran, 1 using warfarin, and they also showed the same thing, that bleeding is much less, and they also showed that there was a non-inferiority achieved. Well, here it looks likely that non-inferiority was statistically okay, and you can believe this. But if you look at the confidence intervals again, so what, for example, my intervention colleagues may be interested in stent thrombosis. So you must look at these tables in detail. So definite stent thrombosis, if you look at the dabigatran 110 arm, there was 1.86 times increase in the stent thrombosis. And if you use a higher dose of dabigatran, then it was much less. So this is better, definitely. And that is why you see in the guidelines, they have said, okay, if you want to use dual treatment strategy, you must use 150 milligram twice a day, because here you can see that the stent thrombosis was not increased, although the confidence intervals are still very wide, 0.35 to 0.28, but still that is somewhat better. The same thing was seen in the Augustus arm also, which was a trial, again, a dual antithrombotic strategy after PCI in patients with atrial fibrillation who require a NOAC for stroke prevention. So what happens here is that some patients were given clopidogrel, and some were given ASA, some were given placebo. Means all patients received clopidogrel, but only half were given aspirin. So some were given aspirin, dual antiplatelet, some were not giving dual antiplatelet. And they again showed the same thing, that the bleeding was much less in dual strategy as compared to triple strategy. But if you look at the stent thrombosis, like the overall adverse events were okay, similar. So death or hospitalization was similar in both the strategies. But if you look at the efficacy outcomes in detail, now this is where I want you to focus on that. If you compare the various things as to what complications happen in which patients, so if you look at individual statistics of death or stroke or myocardial infarction or ARC definite or probable stent thrombosis, you see that if the patients are not given aspirin, the stent thrombosis was more. So with aspirin, it was, say for example, here the event rate is 1, and with placebo it is more. So if you see the hazard ratio is 0.52 if you give aspirin, which means a much lower stent thrombosis if you give aspirin. And if you look at the confidence intervals, they are 0.25 to 1.08. So this is why even this was not significant. Numerically, it was much better, but it was not considered significant because the confidence intervals are very wide. So 0.25 means it could be 4 times beneficial, or 1.08 means it may not be beneficial. So clopidogrel alone may be as good as aspirin. Now, if you had increased the numbers, if supposing the trial had doubled the numbers, it is quite possible that we would have a narrower interval. And that would tell us very clearly that adding of aspirin is definitely beneficial in these patients. So this is what I want to emphasize, that we must look at the fine print. We must look at the confidence intervals of every trial, various findings to see as to whether it is significant or not. Then we come to another very increasingly used statistic, which is called ROC curve. ROC curve, the full form is receiver operating curve statistic. Now, the name sounds very odd, but it has a historical background. So, and this curve dates back to Second World War times, when there used to be uh, radar operators who would receive signal from the aeroplanes, and then they had to take a call whether it's a enemy plane or it's a noise from their system. So that's why it's called receiver operator curve. And so basically, initially it started as whether it's a signal versus noise. And we use this signal versus noise all the time in our tests. Whenever we are doing any test, we want to know whether it's a signal, true signal, or whether it's noise. So in medical terms, we call it specificity and sensitivity. So whenever we are doing any test, for example, we want the test to have a very high sensitivity. In today's context, if we want a test for COVID, we want very highly sensitive test, which means it should detect every patient who is having COVID. So we want the true positive rate to be very high, as close to 100 as possible. And we don't want any false positives. Negative means negative. So false positive is what? 1 minus is specificity. So if the number of false positive on the horizontal, on the x-axis, say 20%, 40%, 60%, as the number of false positive rises, we call it less specific. And as the number of true positive rises, we call the test more sensitive. So for example, if you have a test with a red line, which is like perfectly at 45 degree, which means as the true positives are rising, as the false positives are also rising at the same time. So this is a useless test, because the true positives are also rising or the false positives are also rising. It's a random classifier because it is following a line of like 45 degree completely. So it's a useless test. As the curve pushes higher and higher, the green curve is better, the orange curve is better, the blue is even better, and the purple is a dream, perfect classifier, which means that the sensitivity is 100% and there are no false positives. So it's largely a dream. Very few tests will fall in this category, but we'll be very happy with the, like for example, blue, that for a very significant portion of the curve, the sensitivity keeps rising without losing its specificity. So the way ROC curve is interpreted is area under the curve. So whenever you describe a ROC curve, you want to know what is the area under the curve. Whether it's 50%, 50% would be useless, random classifier. 60%, 70%, 80%, 80% is still good, very good test. 90% outstanding. Beyond that, dream. So we always describe ROC curve as area under the curve, and we want a larger area under the curve. I'll give you some examples. Now, this basically takes us to a different concept, that whenever we do a test, we are trying to find a threshold. So for example, we do a treadmill test. We try to find a threshold that will classify the patient into having CAD versus not having CAD. So we for example, we set a ST depression criteria of 1 millimeter on treadmill test. And that classifies our patients into having CAD or not having CAD. But it has a fallacy, because it's not a perfect classifier. It cannot create two distributions of this patient population into having CAD and non-having CAD. So it will always happen that some patients will not have CAD, but will be diagnosed by treadmill as positive for CAD. And similarly, there'll be some patients who have CAD, but will be missed. They will not be diagnosed. So sensitivity and specificity will be around 70, 75%. You will miss a lot of patients and you will overdiagnose a lot of patients. So if you want to change the criteria, for example, you want to make it 0.5 millimeter, what will happen? The test becomes very sensitive. That means don't miss out any patient with CAD, which is represented by the red pyramid. So red pyramid is of CAD patients. You won't miss out any patients. You will diagnose every patient with CAD. But what will happen is that a lot of patients who don't have CAD, the green pyramid, a lot of them will be diagnosed as having CAD. What happens if you make the criteria more strict? 2 millimeters. You will be underdiagnosing. You will, of course, not overdiagnose. Every patient who doesn't have CAD will not be positive, but you will miss out a lot of patients because they have lesser degree of ST depression, while you have set a criteria of 2 millimeters. So you try to find this is a continuous parameter. You're trying to find a dichotomous relationship. You want yes or no. You want to find a binary solution to a continuous data curve. And that is where we have to set some threshold. And in this case, the most acceptable threshold has been found to be 1. And on the right side, we have the same graph. So this is what happens, that when a test is good, means that it separates your patient population into 2 different distributions. They don't clash with each other. That's when you say that the test is very good, because it is able to differentiate the negatives versus positives very, very clearly. That makes a test very good. A test may not be very good when the 2 distributions start overlapping, and the test becomes quite useless if it is not able to classify or separate your patient population into positives and negatives at all, and there was a high degree of overlap. Just to give some examples from some papers, this is a paper on cardiac MR findings in patients with HCM and atrial fibrillation. And what they found was that there are some things which correlate very well with the risk in HCM patients. Like, for example, there are 3 parameters they've studied: LV mass, extent of late gadolinium enhancement, and LA volume. And this is on the right side, they have area under the curve. So 0.48 is like 50%. It's basically useless. So it doesn't at all. And you can see it is falling in the center line. So it is certainly not good. Extent of LG is slightly better, 0.62, but LA volume was in this particular study the best. So area under the curve was 74% or 0.74. So that was a very good classifier in this particular study. Similarly, you have this quantitative analysis of late gadolinium enhancement in hypertrophic cardiomyopathy, and they've tried to differentiate between the 2 methods. And there is a Rayleigh curve which they derive from certain parameters, and they found very good predictive value, which means the sensitivity is 97%, specificity is 92.3%, and you can see the area under the curve is very high. So it is almost covering the entire spectrum. So this is a very good classifier and very good test for this particular entity or the thing that we are trying to look. Another thing that we see commonly is CIndex. Now CIndex is used, it's quite similar to ROC curve, but it's more often used to see the value of a particular index. Sometimes we have these risk scores like CHADS-VASc or CHADS score or Hasblad score, and we want to see their true value, whether they are good or not particularly good. So, and this is calculated in I usually am not explaining how a particular thing is calculated, but this is something very interesting. So it's called Concordance Index. And this data is, for example, taken from one of the, say, CHADS-VASc score, for example. So we have 10 patients here, which is in the leftmost column, patient number 1 to 10. And they have different risk score from 7, 1, 2, 6 in the second column. And the last column and the third column indicates time to stroke. So we have a high CHADS-VASc score of 7, which may correlate with the time to stroke of 2 years, okay, in the third column in the first row. And the second patient has a score of 1 and time to stroke is 5 years. So that's called a concordant pair, because that's what we expect. We are doing CHADS-VASc to see this only, that if the score is 7, time to stroke is 2 years. If the Charles score is 1, time to stroke is 5 years. So that would be in expectation. That's what you expect. So it's called a concordant pair. A discordant pair is, for example, if the patient has a risk score of 1, of 2, then he has a time to stroke is 1, and the patient who has a higher score of 5 doesn't have stroke. So that's a discordant pair. Then there may be a lot of patients who are lost for follow-up. So one patient, if patient is lost for follow-up, you cannot make any decisions. So you have to exclude this pair. Again, you have a concordant pair. Again, you have exclusion because some patients are lost to follow-up. And this is particularly helpful where a lot of patients have attrition or they exit the study. So we call that censoring. I discussed in the last lecture as to what is censoring. Censoring is when there's a lot of data loss from the study because of patients exiting or dying. So you're not sure about what happened to them. So we have to exclude those pairs. And then concordance index or CIndex is calculated by number of concordant pairs divided by total pairs. So in this example, you have a concordance index of 2 by 3, that is 0.66. So that's how a concordance index is calculated. And again, similar to ROC curve, a value below 0.5 indicates a very poor model. 0.5 means it is neither good nor bad, it's just a random classifier. 0.7 indicates a good model and 0.8 indicates a very strong model. So when we evaluate any risk score system, we like to have a good CIndex. And this is what I was telling you about the censoring. So, and this is a survival curve. When we draw Kaplan-Meier survival curve, the probability survival of any free of any outcome. But you see a lot of things here, no, a lot of data is censored. So this plus sign they have mentioned as censored. So we must know what exactly censoring means, that patient was lost to follow-up or died of some unrelated outcome. And this is a paper like, for example, ABC death risk score for atrial fibrillation. And they have, again, like mentioned, it was well calibrated, a higher CIndex than a model based on all clinical variables. So CIndex was 0.74 versus 0.68. So this is how the CIndex is interpreted. It should be a higher value is better compared to the lower value. And this is, for example, CIndex for mortality according to the ABC death score as compared to Charles-Basque score. And they have found that this ABC death score was better. So lastly, we come to how to interpret a meta-analysis. So meta-analysis, as we discussed last, I briefly alluded to last time, that there may be so many studies done on a particular aspect, a particular treatment or particular risk score or anything for that matter. And not all of them will give good results. And sometimes they show a trend, but then trend is weak trend or may miss significance. So sometimes it's a good idea to pool all the studies together and see what the pooled data shows, because that can give some important information. But as I told last time, it may happen that 50 studies are done all across the world on a particular disease, and out of 50, only 5 were positive and 45 were negative. And out of 50, only 5 were published, and maybe 2 negative were also published. So total 7 were published, and 43 which were negative were not published. So it may happen that when we do a meta-analysis, we take only the positive studies and maybe 2 negative studies, and forget, we don't know because they were not published. The 43 were not published, which were negative. And we may come out from the pooled data, we may come out with a strong positive signal. Now, that is something not representative of what truly happened. And nowadays, there is an increasing practice of utilizing the unpublished data also from the trial registries, because a lot of data exists in the trial registries, in the regulators registries, because many trials are submitted before for approval, and then the investigators have to submit the results also to these regulators and the registries get final clearance, or to sometimes to get reimbursement for their studies and all that. So that a lot of data exists which is not published, and it's a good practice to get that data also. Only then the meta-analysis can be considered good. Meta-analysis like garbage in, garbage out. If your selection of studies has to be very, very meticulous and appropriate, because there can be a lot of biases involved in meta-analysis. One of them, of course, is the selection bias. Then you can have publication bias. Then there may be heterogeneity between studies, which has to be quantified. So I will show you how they quantify the heterogeneity between the studies, and that has to be looked at. So whenever we look at any this thing, and of course the quality of studies, there is a Newcastle Ottawa scale for us understanding the quality of studies also. But heterogeneity is something very important. So for example, you cannot throw all bunch of data and into one mathematical equation, because that will be a wrong thing to do. So whenever we are trying to assess anything, just continuing our same line of thinking on, say for example, the NOAC trials. So this is a meta-analysis of 3 trials: the WOOS trial, the Pioneer AF PCI trial, and the Redual PCI trial. And they have shown certain results here, and they've shown that when the pool data was taken, it showed again the same signal, that there was a reduction in the bleeding tendency while the efficacy was preserved. There were not no significant incidence of bleeding, ischemic complications. But so there is a value whenever you see these meta-analysis graphs. You must look at this value at the bottom left, I square. This is what indicates the heterogeneity. So this is it can be computed in the range of 0 to 100. If it is less than 25%, that indicates a low heterogeneity, which means that the studies that were compiled and into a meta-analysis were similar. And 25% indicates moderate heterogeneity, and more than 50% indicates substantial heterogeneity. So in this, these two graphs, you can see that in the upper one, the I square is 82, which is a high heterogeneity. And in the lower one, it's 51, still moderate heterogeneity. So the 3 studies are not very similar to each other. The data has been compiled, but everything has to be interpreted in the light of heterogeneity. So this is something that we must keep in mind, the heterogeneity in different studies. There may be other studies which show lesser heterogeneity. This is for example, a NOAC trial. There was a meta-analysis published by Ruff et al. Rely, Rocket AF, Aristotle, and Engage, all the 4 trials. And they showed similar results that favored NOAC. But even here, the heterogeneity was moderate. They were not very similar because they differed in their age groups or in the Chadsworth score. For example, the Rocket AF had much higher average Chadsworth as compared to the Rely trial. So they differed in substantial manner. And this I square indicates as to how heterogeneous the data was. And this is, sorry. Yeah, this is the same thing represented in different manner. So you can say here the same thing which I showed in the beginning, that all these this data in the same meta-analysis was compiled into different subgroup analysis, age more than 75, less than 75, and some of them are showing difference, some of them are not showing difference. And on the right side, you have the P interaction between these subgroups. One thing which I want to emphasize is that whenever we look at subgroup analysis, we must look at the methodology section and see whether this subgroup analysis was pre-specified or not. Because if a subgroup analysis was pre-specified, that would mean that it has a statistical value, because they must have taken into account the total numbers and expected results, expected difference between different groups, and accordingly they would have calculated the numbers. But a lot of this subgroup analysis is done post facto. in the post hoc analysis, which doesn't carry much statistical weight. It can at the most be considered hypothesis generating. That is, it can lead to further clinical trials. But within that particular trial, a post hoc analysis doesn't carry much weight. You can't base it can't inform clinical practice. So that is something important to understand. Lastly, we come to the Kaplan-Meier survival curves as to how we do survival analysis. Now, whenever we do any treatment, do a trial, there are different treatment options or different exposure to different drugs, and that leads to different survival curves. We are looking at survival free of any particular outcome. So there may be two survival curves which are comparing the mortality, but there may be other curves which may be comparing stroke or heart failure or number of hospitalizations. So all of them are called survival curve. It's not like always mortality. So wherever we are looking at any particular outcome happening or not happening, we call them survival curves. And as I talked in the last presentation, we must assume that there is no difference between the two curves. So when we do a study, we go with the null hypothesis, which means that we always assume, like for example here, you do a study, this is from the Cabana trial, you find that the drug therapy has a certain curve of say in this say event rate percentage, and the catheter ablation harm has a different curve. So you want to know whether this curve is significantly different or not, or it happens just by chance. So you always assume you go with the null hypothesis. You begin the trial with the null hypothesis that both the curves are same. But you see a divergence. You see that the two curves are not looking similar. They are different. So you want to know whether this difference can occur. It is compatible with the null hypothesis or not. And that is what the p-value here will be. That you want to know the probability that this difference between the two curves is compatible with your null hypothesis, that two groups are similar. And that probability of less than 5%, you reject your null hypothesis and you accept the alternative hypothesis that these two curves are different. So the test that we do for survival curves is a log rank test. And with the log rank test, you calculate the p-value again, and you find whether it is less than 0.05 or not. In this example, in the Cabana trial, they found that the p-value was 0.3, which means that this difference that we are seeing here is not significant. The probability is 30% that this is a chance occurrence. This difference is chance occurrence and not due to true improvement by the catheter ablation. So that's why the trial was considered negative. And there are different same things. So it can be seen as now here it was different. For example, this was a different analysis, and they found that the mortality of cardiovascular hospitalization log rank p less than 0.001. So this was considered significant. So that's how you analyze the survival curve by the log rank test. So I think I can stop here. I'll be very happy to answer if there's any question.
Good evening, sir.
Good evening.
Sir, one thing I would like to ask is correlation coefficient, sir.
Yeah, so correlation and regression, that is something which I should have covered, but I did not cover. Now, correlation coefficient basically means that one variable correlates with another. So for example, you look at one variable could be number of cigarettes smoked, and another variable could be incidence of coronary artery disease. So if you try to find a correlation between in a large population with number of cigarettes smoked and incidence of coronary artery disease, you will find that there is a correlation. So that is called correlation. It's called Pearson correlation coefficient, which is represented by the letter R. And a value of 1 indicates perfect correlation. A a value of 0 indicates no correlation, and a value of -1 indicates perfect negative correlation. Usually we find something around 0.67 if there is a good correlation. So anything 0.6 or more is considered good correlation. 1 would be perfect correlation. Now, correlation does not always mean causality. It's not always related to the same. For example, if you say if you find correlation between gray hair and malignancy, you may find a correlation that people with gray hair have more malignancy because they both correlate with the age. Malignancy occurs in old age and gray hair occurs in old age, or cataract with the cancer. But that doesn't mean that they're causally related. So correlation just means that there is a correlation between the two. And another thing which is similar to correlation is called regression analysis. Regression means that you can predict one parameter from another. So if you have in regression, you have one target variable that you want to predict, and you have a independent variable that is the calculation is used to predict a particular target variable. And example I can give you, for example, we have this app which calculates the expected HCM risk, for example, the sudden death risk from various high HCM parameters. Or there is a app which calculates the expected cardiovascular disease, atherosclerotic disease rate from different parameters, your age, your LDL cholesterol, your cigarette smoking, your obesity, and all the parameters are used. Multivariate analysis is done to a regression analysis to predict a particular outcome. So regression analysis is used to predict one variable from another, and correlation just correlates the two variables without any causality.
That's very well explained, sir.
Propensity matching is another term that is commonly used in many of the articles. So what does propensity matching
propensity matching is used when you cannot compare the two populations directly, or you want to correct them for propensity matching. So when you don't have randomized study, you have case control studies, then they use propensity matching, because in many diseases it may not be possible to do a randomized study. You cannot randomize because either the treatment is very expensive or very complicated, or something very new, or something which is it is unethical to randomize. You can't withhold a particular treatment. So you want to compare one group from another, which is non-randomized, but you want to do propensity matching, that both should have similar risks, or you correct them for certain variables, and you try to do propensity matching that these two groups were similar in their propensity for a particular outcome, but this treatment has changed that, so it has caused a difference. So that's called propensity matching, that you see whether the two groups are matched or not for that particular propensity for that outcome.
Now, we already have a study done in the addressing the same issue, and we want to do a fresh study. So, what is the best and the simplest way to do the sample size calculation? Which parameters?
I don't know sample size, because, as I said, I'm not a statistician, and I really don't even want to learn how to calculate, because there is so much to study, so much to learn. And as such, it is best to know what there are so many things which I have not discussed, and we should focus on what statistics should be used when, and how to interpret it, or how it is expressed and how it is interpreted, and what precautions we should take, rather than trying to take the job of statisticians, because we must leave it to them. And the moment we try to segregate ourselves from the statisticians' work, then your interest will increase in statistics, because you're not interested in calculations. And that is a big deterrent. Whenever I wanted to go deeper into anything, that would dissuade me from studying statistics further. Because there's so many statistical models, and they're very complex and very hard, difficult to understand. So
Dr. Saxena,
I can't, I'm not competent enough to do even all those sample calculations, and even the numbers needed to treat and this and that. Those calculations I will leave to statisticians.
Otherwise, do you recommend any simple book or an article? Some people are writing and asking that for residents and fellows to know about all these things that you have described.
Yes,
It's
there are
like
a couple
normal,
of
yeah.
books
So, which
which are
common?
relatively easy.
Yeah,
Maybe I
that is
will
what.
I will give it, send it to you, and you can circulate it to the
Surely. So I'll mail it to you, mail it to all the residents and post it on the
definitely,
YouTube, so you can
definitely.
definitely have a look. That will be
Yeah.
great. If there are any other questions, Dr.
What
Sumant?
is standard error, sir? Standard error is another term that is commonly used.
Yeah, standard error again. Basically, as I said, there are measures of dispersion where we try to find how a data is. Whenever we encounter a large data set, a data population or a data distribution, we are interested in two things. One is standard. One is the central tendency as to what is the mean, median, or mode, and what is the spread. And so the spread is reflected in the either in the data range or in the standard deviation or in the variance. So when you calculate standard deviation, you calculate standard error also. I think I may not be without any slide. I will not be able to explain it fully well, but it is calculated there to find what is the um, a particular measure is called standard error of mean.
Okay, thank you so much, sir, for this opportunity, and thank you so much, sir, for sharing your thoughts on statistical primer for medical professionals. So, as you can see, that we have got an overview of what are the basic things that, as a fellows and as a, practicing clinicians, especially when you are writing papers, interpreting these studies, and reading them, what are the things that one should know? And you can definitely, if you want, dig deeper into this, and if you want to have a more elaborate knowledge, I will be sharing the book, that is the link to the book or the book itself, once I am told about the same by Dr. Anil Saxena. And the same lecture, the part 1 is already loaded. This part 2 will also be uploaded on the YouTube channel. So these were two out of the box lectures on your demand only, that you wanted to have a statistical primer for your studies. Thank you so much, sir, for doing a terrific job. And next week we'll be joining you again at the same time with a different lecture, and we'll be sharing the details soon with you. In case you have any questions, any comments, please write to us on pgtrack CSI Delhi branch at gmail.com. We would also be very happy to you to subscribe to the channel, which is absolutely free of cost, where all the 34 lectures are uploaded, and these lectures have been great, and we've got been getting messages from across the country that students have really benefited by these lectures. So you can definitely connect and download all those lectures. And I thank you, Intas, for providing us this platform. Thank you all, Dr. Ankit, Dr. Sumod, Dr. Satyaveer. Always just a call and everybody is here and joining hands for this wonderful academics. Thank you, Dr. Saxena, and we'll keep
Thank
on
you.
troubling you, especially for the electrophysiology and the EP lectures in near future, which we are
Anytime.
planning
Thank you
soon.
so much.
Thank you so much, and
Thanks
see
a
you
lot.
till then. Goodbye, and have a great weekend. Thank you.
Thank
Thank you,
you.
sir.
Thank you,
Thank
sir.
you.
Thank you, sir. Thank you.